Greetings from Surendra Dental College and Research Institute, Sri Ganganagar. Myself, Dr. Suruchi Juneja, will be discussing obturation of primary root canals in this presentation. We have already discussed the previous steps of pulpectomy, that is access opening and preparation of root canals. Now coming to obturation. So basically the purpose of obturation of root canal is to create a fluid tight seal along the length of the root from the coronal opening to the apical system, and thus eliminating all the portals of entry of microorganisms between the periodontium and the root canal system. First of all, why different obturating systems for primary teeth? First and foremost is the differences in the morphology of the primary and permanent teeth. The root canals, they are long, they are more flaring, and they are tortuous in morphology in primary teeth. Thus, it precludes the complete debridement of the root canal system. Therefore, a material which is used for this obturation would definitely be different from that used in permanent teeth, wherein the root canals are straighter with lesser ramifications and a more complete debridement of the root canal system. Second is the desired timely root resorption of the primary teeth, which is required so as to allow the eruption of the permanent succedaneous tooth. And third is the difficulty in obtaining a good radiographic view of the apex of a primary tooth due to superimposition of the permanent tooth buds, and because it is a two-dimensional image of a three-dimensional object. So the materials which are meant for obturation of primary root canals should have the certain properties according to Rifkin and Machida. First of all, they should resorb at the same rate as the primary tooth does. They should be harmless to the periapical tissues and permanent tooth buds. It should easily resorb if extruded beyond the apex. It should fill the roots easily. It should be antiseptic, should adhere to the walls, should not shrink inside the canals, and be easily removed if required. It should be radiopaque and should not discolor the tooth. Following are the various obturating materials which are used for obturation of the primary root canals: zinc oxide eugenol, calcium hydroxide, iodoform, Vitapex, Walkhoff paste, KRI paste, Maisto paste, mineral trioxide aggregate, endoflas, and many more. Now here, the gutta percha is not indicated for obturation of the primary root canals except for one single condition: when the tooth in question does not have the permanent successor. Only then the gutta percha can be used. It is a singular indication of using gutta percha in the primary obturations. Discussing one by one, zinc oxide eugenol. It was the first root canal filling material to be recommended for primary teeth by Sweet in 1930, and it has since then been the gold standard. We'll be discussing the disadvantages because the advantages are less as compared to the disadvantages. It can cause necrosis of the bone and cementum, and since it resorbs at a pace slower than the root, so it can stay there even after the resorption of the root, and thus it can prove a hindrance to the eruption of the permanent teeth. So it can lead to malformation of the succedaneous tooth. It can irritate the periapical tissues. It can also alter the path of eruption of succedaneous tooth because of the unresorbed material beyond the apex. It has been seen that the zinc oxide eugenol material, when extruded, it did not reduce in size even after 10 to 16 months of follow-up. A commonly used material is calcium hydroxide. However, singularly it is not used because it is resorbing quite quickly within the canals, and extruded calcium hydroxide also resorbed within 3 to 4 months. It is usually used in combination with iodoform paste as Vitapex or Metapex. It is the closest to the ideal for root canal filling material in primary teeth. It is a yellow soft paste with iodoform odor. It is radiopaque and has excellent antibacterial characteristics due to the presence of iodoform. The composition is 40% iodoform, 30% calcium hydroxide, and the rest is formed by the silicon oil. This silicon oil or the oil-based consistency leads to lesser resorption. However, Uh, the advantages associated are bone regeneration, which can be seen clinically as well as radiographically. When extruded out of the apical area, it can be easily resorbed. The disadvantages are it is the least antibacterial effect compared to the maisto paste, iodoformized zinc oxide eugenol, and KRI paste. Therefore, not indicated for aggressive treatment. So, antibiotic therapy may augment the treatment with Vitapex. It resorbs even intraradicularly, leading to the hollow tube effect. Hollow tube effect is the effect or the resorption seen a few months after the treatment when the canals are left unoccupied or vacant after the resorption, and it often leads to reinfection. So that is why better materials are advocated. A recent material is endoflas paste. It is similar to Vitapex, but however, it also contains zinc oxide eugenol. The powder contains triiodomethane, zinc oxide, calcium hydroxide, barium sulfate, and iodine dibutylo-orthocresol. The liquid contains eugenol and paramonochlorophenol. As compared to the other paste, it resorbs when extruded extraradicularly but does not wash out intraradicularly. The main disadvantage of endoflas paste is the handling. It is difficult to handle, and once it sets, it cannot be pushed as Vitapex or Metapex can be. Another is Walkhoff paste, which was introduced in 1928. As discussed already, it is consisting of a mixture of parachlorophenol and camphor and menthol. Maestro's paste, which was developed by Masto and Eraxin in 1965. It is composed of zinc oxide, eugenol, iodoform, thymol, chloromonochlorophenol, and anhydrous lanolin. The advantages are it has better antibacterial activity compared to iodoformized zinc oxide eugenol, KRI paste, and Vitapex. KRI paste contains iodoform, camphor, parachlorophenol, and menthol. Advantages being easily forced into pulp canals and accessory canals, absence of any foreign body reaction which is seen with zinc oxide eugenol, potent germicidal action, it resorbs in synchrony with the primary roots, it is easily resorbable from even the periapical areas after extrusion, and there is no undesirable side effects on the succedaneous teeth. Another paste that is used for obturation is GPP paste. Gates Pinto et al. In 1981 proposed root canal filling material for primary teeth, which is named as GPP paste. It contains Rifocort, that is steroids, camphorated parachlorophenol, and iodoform. This paste is made up of equal part of each component, and then it is mixed just before the use on a sterilized gas plate. Other obturating materials are Smart Seal, which is a polymer-based material, Rifocort, it is a steroid, aloe vera, which can be used as an alternative to zinc oxide eugenol, and CTZ paste, which is a combination of chloramphenicol, tetracycline, zinc oxide, and eugenol. There's another technique called as LSTR, which is lesion sterilization and tissue repair. Also called as non-instrumental endodontic treatment. It is a newer biological approach for the treatment of carious teeth with or without pulpal or periapical involvement, but it can also be used in teeth which have a very poor prognosis. LSTR employs the mixture of three antibacterial drugs, also called as triple mix or trimix, which can sterilize the carious lesions, infected necrotic pulps, and infected root canals. Here in LSTR, no mechanical instrumentation is performed, and thus it prevents enlargement of the root canal and unnecessary irritation of the periapical tissues. The advantages are the highly antibacterial effect or the non-instrumentation technique is more suitable for cases with poor prognosis, and it lessens the chairside time. The disadvantages are if a focus of chronic inflammation is left behind, then there is always a risk of damaging the permanent successor or cyst formation. And the minocycline, one of the components of this triple mix, can lead to staining of permanent tooth due to a distribution of 3-mix paste. Coming to the methods of obturating primary root canals, there are many methods proposed: incremental filling technique with the help of a reamer, amalgam condenser, moist cotton pellet with the help of a file, lentillar spiral, bidirectional spiral, pressure syringe, tuberculin syringe, navy tip, and paste inject. Reamer, file, they are all stiff and they can just place the material in the canal. However, there are voids associated. Lentillar spiral and bidirectional spiral, they are rotary instruments which can be used to place the pastes in the root canal system. Navy tip has a very flexible tip which can be used. The chosen obturation technique basically depends on the material employed and the accessibility of the canal to the relevant instruments. So we will be quickly discussing just two of these commonly used materials. First is lentillar spiral, which can be used by hand or can be rotary. The size 25 is used for mesial canals usually, and 40 can be used for distal or the palatal canals, or even for certain mesial canals which are quite large in size. The use of two sizes smaller than the mastoapical file and is advocated, and it is kept 1 mm short of the apex. Another method is using endodontic pressure syringe. It was developed by Greenberg and Katz in 1961. Greenberg recommended filling of the root canals with thick mix of resorbable paste using this injection technique. The flexibility of thin needles which are used allows the placement of material to the apex and even in the fine tortuous canals. Since the apical portion is filled first and the remaining canal is filled under pressure, this flows regularly into the irregularities both laterally and apically. Now, criteria for evaluating the obturation is different according to various authors. In 1996, Call and Sadrin classified the obturation as short fill, complete fill, or long fill. Short fill means all the canals filled 1 mm or more short of the apex. Complete fills indicated one or more canals having zinc oxide eugenol ending at the radiographic apex, and long fill means beyond the apex. It was later modified by Bawazir and Salama. According to them, canals should be filled 2 mm or more short of the apex. Regardless of the method used to fill the root canals, care should be taken to prevent the extrusion of the material into the periapical tissues. So, underfilling is always better than overfilling the root canals. Thank you so much for your patience listening.